Bismillahirrahmanirrahim. So today we will discuss about the hyponatremia again, but yesterday we have discussed about hypotonic hyponatremia, and today we'll discuss about hypertonic and isotonic hyponatremia. Basically, the hyponatremia has three types. First is the hypotonic hyponatremia, second is the hypertonic hyponatremia, and third is the isotonic hyponatremia. But first type, that is hypotonic hyponatremia, is further divided according to the volume. It's hypovolemic hyponatremia, euvolemic, and the hypervolemic hyponatremia of the hypotonic hyponatremia variety. Let's talk about the hypertonic first and then we'll move towards the isotonic. In this condition of hypertonic hyponatremia, the plasma osmolality will increase because the word hypertonic is written. Plasma osmolality in this condition would be more than 295 milliosmoles. Okay, it would be more than 295 milliosmoles per liter. But normally the plasma osmolality is from 275 to 290. Okay, but it's more than 295. It means that plasma is hypertonic. But what are the conditions that leads to low sodium in the plasma? Let's talk about the etiology. Before talking about the etiology, I have told you that plasma is dependent on four factors. The plasma osmolality depend on sodium and potassium. Okay, this is the formula I'm writing here, and plus blood urea nitrogen divided by 2.8, and glucose divided by 18. This is the formula for the calculating the plasma osmolality. So sodium is concerned, potassium, blood urea nitrogen, and glucose. These four are very important in determining the plasma osmolality. So what are the etiologies? What are the causes for the development of hypertonic hyponatremia? First of all, the cause is high amount of glucose present inside the bloodstream. For example, if a patient is suffering from hyperosmolar coma because there is diabetes mellitus, hyperosmolar coma. You know that diabetes mellitus, when there is huge amount of hyperglycemia, it can leads to hyperosmolar coma. And what is the pathophysiology? This glucose is osmotically active. It will cause the water to move into the bloodstream. The water level will also increase inside the circulation, and it leads to dilutional hyponatremia. Dilutional hyponatremia. Okay, it is due to the glucose that is causing pull of water from the cells or ECF into the bloodstream, and it will cause dilutional hyponatremia. The studies have shown that for every 100 milligram percent increase in sugar, 100 milligram percent increase in the glucose or sugar, it leads to 1.6 milliequivalents of sodium to go down. What does it mean? It means that when glucose is there will be less amount of sodium in the blood. So we can make a statement that glucose and sodium, like sugar and sodium, are inversely proportional. They have an inverse relation. Because glucose is hyperosmotic, it will pull the water, and the water content of circulation increases. It leads to dilutional hyponatremia, and 100 milligram percent of glucose rise will result in 1.6 milliequivalent fall of the sodium. It means that glucose and sodium are inversely proportional. What other etiological factor can be there apart from hyperglycemia? It can be mannitol. What is mannitol? Mannitol is osmotically active substance or molecule. It creates osmotic gradient for the water. For example, if a person is having mannitol toxicity, it will definitely lead to hypertonic hyponatremia. What other? The contrast, radio contrast. contrast. For example, barium. Barium is used in the radio contrast for X-ray, right? So mannitol, contrast, radio contrast, they are both are hyper, like they are osmotically active substances, and they will, the pathophysiology is the same. They will attract the water and it will lead to dilutional hyponatremia. Let's talk about the next type, that is isotonic. The last type I would say probably is the isotonic hyponatremia. Isotonic, what does isotonic means? Isotonic means that plasma osmolality is normal. Plasma osmolality is normal. But why there is hyponatremia? Actually, this type of isotonic hyponatremia is also known as pseudohyponatremia. Pseudohyponatremia. In this condition, the amount of salt in the blood is normal. It means that total body salt is normal and the osmolality is also normal. But why is there hyponatremia then? When the amount of salt is also normal, when the amount of the plasma osmolality is also normal, why there is like hyponatremia component coming? It is due to the lab errors. It is due to the lab errors. The technician or the physician error can result in the formation of isotonic hyponatremia. Either the lab instruments are dysfunctioning, or the other reason for that is the presence of other molecules. For example, hyperlipidemia. Hyperlipidemia. And also the next condition is hyperproteinemia. The large amount of proteins or lipids present inside the bloodstream can alter the calculation for the sodium. Hyperproteinemia, it's not hypo, it's hyper. So it's hyperproteinemia. What is the example for hyperproteinemia? It's the paraproteins. Like paraproteins are formed in this condition, and other type of proteins that are formed in the hyperproteinemia are the Benz-Jones proteins. Benz-Jones proteins. But why these proteins are being formed? There is a condition known as the multiple myeloma. Multiple myeloma is the abnormal production of plasma cells, right? Multiple myeloma. So what is isotonic hyponatremia? It is called as the pseudohyponatremia, in which the total blood salt is normal, total body salt is normal, the osmolality is normal, but due to the lab errors, the other values interfere with the measurement of sodium, like lipids and proteins, like Benz-Jones proteins and paraproteins, which are due to multiple myeloma. These molecules can alter the values of the sodium. So let's talk about the management aspect. Management of chronic hyponatremia. Management of chronic hyponatremia. So the patient is suffering from hyponatremia, right? But how we gonna treat that patient? What is the management aspect? So let's discuss it. The management, the fluid of choice. The fluid of choice is the hypertonic saline, that is 3% saline. Normal saline is 0.9%. Normal is 0.9%, but in this condition we are having a hypertonic saline because the normal saline contains 154 milliequivalents of sodium and also 154 milliequivalents of chloride. But in this condition we do not want normal saline to cure the patient. We want hypertonic saline, and it contains 514 milliequivalents of sodium. It's contain a huge amount of sodium. That's why we are treating hyponatremia component. But the main thing is that there should be a gradual increase in the sodium. Gradual increase in sodium. When managing a patient of hyponatremia, the doctor should be very careful because they should give a slow slow infusion, right? The sodium should be pumped into the bloodstream of the patient via infusion pumps very gradually. Gradual increase, for example 4 to 8 milli equivalents should be given in 24 hours. What does it mean? It means that, for example, if a patient has a laboratory value of sodium 120, so in the next 24 hours we should only increase by 8. It's 128. And in the next 24 hours it should only be increased by 8, 136, and then in the fourth day or third day it returns to the normal value, that is 144, because the sodium value normally is from 135 to 145 milliequivalents, right? We should have a gradual increase in the sodium values of a patient. Why is it important to discuss? Because a abrupt change, or we can say fast correction of the sodium can manifest stroke-like conditions. Fast correction of sodium will lead to stroke-like manifestations, and it is very clinically important because this condition is known as cerebral pontine myelinosis. And this condition is very like lethal. Cerebral pontine myelinosis, the patient would never be able to walk and talk again because of the fast correction of sodium that is being given in the ward, right? So it's very important that sodium should be given gradually. Nowadays the cerebral pontine myelinosis is having a other name, that is known as the osmotic demyelination syndrome. Osmotic demyelination syndrome, because there will be demyelination of corticospinal tracts. Demyelination syndrome. What is the manifestations of cerebral pontine myelinosis or osmotic demyelination syndrome? First, there will be quadriplegia. I have said that the patient will not be able to walk again. Quadriplegia, paralysis of all four limbs. Then there will be Babinski positive. Babinski positive. What is Babinski sign? It is positive only in infants and neonates. Babinski is that when we stroke the sole of the foot, the big toe will move upwards and the other toes will fan out. This is the Babinski sign. Mostly positive in neonates, but in condition of cerebral pontine myelinosis, this sign will be also positive in adults. The third condition is the demyelination of corticospinal tracts. Demyelination of corticospinal tracts, right? So it's a very dangerous situation due to the due to doctor error, due to paramedic error. The patient is suffering from osmotic demyelination syndrome due to only the fast correction of sodium. Let's discuss a case here. The case is that there is an athlete, 60 kg athlete, that is female. Okay, she is a female and she has hyponatremia. When we have checked her blood sodium levels, it came out to be only 120 milliequivalents per liter, and she was brought to hospital because she collapsed during the marathon, and she also has the episodes of seizures, because I have told you that low sodium below 125 can lead to seizures. It can lead to cerebral edema, right, due to fluid shift across the brain. 60 kg female has hyponatremia. The question is that what is the sodium correction to be given over 24 hours? Over the next 24 hours, what is the sodium correction formula? What is the sodium correction? Using the sodium correction formula. So let's discuss what is the sodium correction formula over 24 hours. It's very important to write 24 hours. So it's the total body water of the patient multiplied by the desired value. What is the desired value? What we are looking for in 24 hours desired value, and from desired value we should minus the actual value of the sodium. Minus the actual value. What's the actual value? It's 120, right? And what is the desired value? We'll come to it. First we should discuss that how to calculate the total body water. The total body water can be calculated by multiplying the weight of the individual. In case of females it is multiplied by 0.5, and in case of males it is multiplied by 0.6. Okay, in case of males and females, so it is the male, no, sorry, it's 0.5 in case of females, right? It's the female, and 0.6 in case of males. Athlete is mentioned to be a female, so let's calculate the total body water. What is the total weight? It's 60 multiplied by 0.5. Okay, the total body water is sorted. Then the desired value. What is desired value? I have told that the laboratory value when she was brought to hospital is 120 milliequivalents per liter. But what I have told you that in 24 hours we should only increase 8 milliequivalents. In 24 hours only 8 milliequivalents of the sodium should be increased. It means that the desired value is 128. It's not 136, it's not 144, it's only 128 according to the plan. So desired value is 128, and from the desired value we should minus the actual value, that is 120 over 24 hours. That is very important. So what calculating all these values, the last value will be 240 milliequivalents over 24 hours. This is the sodium correction formula over the next 24 hours. And what is 240 milliequivalents? We are only increasing 8, but why is the answer saying that 240 milliequivalents per 24 hours? Because in a patient of the sodium value of 120, when we give the infusion of 240 milliequivalents over 24 hours, the value of the sodium will increase from 120 to 128. And in the next 24 hours, we again give the 240, then this will increase to 136. And in the next 24 hours, again we give 240, and this will cause the sodium to become normal again. And this 240 milliequivalents of the sodium is not given abruptly, it's given over 24 hours in 3% saline. Okay, in 3% saline, very slowly via infusion pump. Okay, it's very important because we are preferring 3% saline over 0.9% saline because the patient is hyponatremic, so hypertonic saline is used, and this is the formula for the sodium correction. Let's talk about some little bit of more information. I have told you that fluid of choice is 3% saline. Here, the fluid of choice is 3% saline. It's the fluid of choice to treat the hyponatremic conditions, right? 0.9% saline contains 154 milliequivalents of sodium. It contains 154 milliequivalents of sodium. And 3% saline contains 514, just altering the numbers, right? 540 milliequivalents of sodium, and these are over 1000 ml. These are over 1 liter of the fluid. If we want to calculate that 1000 ml is containing 154 of the normal saline, and 1000 ml is containing 514 of sodium in 3% saline. So it means that 1 ml of normal saline, that is 0.9% saline, will contain 154 divided by 1000. Okay, and it comes out to be 1.54 milliequivalents of sodium in 1% of normal saline. But what about the 3% saline? Again, 1 ml of 3% saline will contain how much amount of sodium? It will contain 514 by 1000. So it comes out to be 1.51. 0. So it's 0.51. Okay, and it's 0.54. Sorry for the misunderstanding. It is the 0.54 and 0. It's 154, and when we divide it by 1000, it's come out to be 154, and when we divide 514 by 1000, it comes out to be 0.51. So that's the mathematical part in case of hyponatremia. And the last but not the least is that what is the final formula? It's the total body water multiplied by 8. It's the formula for the sodium correction. Why I'm saying 8? Because the desired value is always 8 more than the actual value. I repeat my statement, the desired value is always 8 points more than the actual value. So it's the mathematical formula in the end of the day. And this formula is over 24 hours, and the value that comes should be given via infusion pump in 3% saline over 24 hours. Okay, via infusion pump over next 24 hours in 3% saline. This was for hyponatremia, and in the next lecture we'll discuss about hypernatremia and its